Hey everyone, my name is Dr. Galatia Strong. I'm a physical therapist who got 100% on my NPTE, and this led me to co-found SPT with me, which is an NPTE prep course. If you end up enjoying this video and want to see ones that are more tailored towards the NPTE, please check out sptwithme.com for our full NPTE study experience. Now, onto what you're actually here for, let's talk about referred pain. Referred pain, and specifically visceral referred pain, is an interesting concept because the idea is that the pain that you might be feeling from your stomach or your heart or your appendix, which again is pain from a visceral organ, is that this pain is not actually felt at the organ. This pain is perceived at the skin from the brain. Now think about the last time that you had either the stomach flu or a stomach ache. You probably had your hand on the region near your stomach, but if you really consider the difference between the sensation that you get if you were to get a paper cut versus a sensation that you would get from a stomach ache, it's very different from each other. With a paper cut, you can feel exactly where the pain lies. So for example, you look at your finger and you can say, yes, this is exactly where I'm feeling that pain. It's exactly where I see it. However, with visceral pain, such as with your stomach, with a stomach flu or stomach ache, you might kind of put your hand, around the midsection of where your stomach actually lies, just under your sternum. And it's pretty much where the stomach is, but from your own experience, what I'm trying to suggest is that this pain is not localized as much as a paper cut would be. So that's one thing to consider. Now, with this example of a stomach ache, like I said, the pain that you feel is pretty much where the stomach actually is. However, as you can see from this chart, just think about the kidneys. Your kidneys definitely do not span the front and back region of your lower abdomen or even traversing down towards the lateral aspect of your legs, right? The kidney structures are way smaller than that, right? You think about T12 to L3. This is way beyond that. So why is it that your kidneys might have such a broad region that it's covering with respect to referred pain? Well, the theory behind referred pain is that if your organ is experiencing some sort of noxious stimuli or some sort of pain, whatever spinal cord level it is that innervates that organ, your brain is going to perceive that pain as being at the same spinal cord level with respect to the cutaneous region. So to give an example, let's talk about your appendix. So go ahead, find the appendix on this screen. Your appendix is innervated by the level T10. So let's say you have something extreme like appendicitis, very painful, right? So your T10 nerve is going to be sending signals up to the brain. So the level T10 is saying that something is wrong to the brain. Your brain is going to interpret that pain at the T10 dermatomal level. Dermatomes meaning the cutaneous sensations that we have. Now, if you've memorized, the T10 dermatomal level traverses the umbilical cord. It's at that level. So look at the screen and you're going to see that the appendix kind of traverses this T10 area, right? But really, you could see it covers a broader range according to this illustration. So it looks like maybe, T10 down to T12. This brings me to another point. First of all, there are so many images about referred pain on the internet. Your own instructor might have a different picture than I'm depicting. The textbook that you're using might have a different one. And there's a reason for that. Why there's so many different pictures with so many different regions covered? Well, that's because research, that's because it's research, right? It shows different regions. So unfortunately, we still don't know everything, and that's why we have theories and not facts. So that's just one thing to consider. Now, the second thing to consider is that clearly these illustrations are not completely accurate, and each person might experience something a little bit different from another with respect to visceral pain and where they sense it. So to go back to that example, in this picture, appendix T10, might cross the T10 region a little bit. However, again, it's kind of traverses down to T11, T12. And I can give an example for myself about the accuracy of these images. So one time I needed to get an ultrasound of my uterus. So as a result, I have to drink a few cups of water prior to that just so the image can be extra clear. But I ended up having to wait a very long time until my image. So long to that to where my urine was essentially backing up toward my kidney. And I literally felt my right kidney have pain, which is incredibly scary. But the pain that I felt was not what this image illustrates. The pain that I felt was actually very localized to where the kidneys actually are, or the right kidney actually is, which is between T12 and L3. Now, another example, I want you to think about heart attacks, myocardial infarctions. So this schematic pretty much does represent what a male would feel. So your heart is innervated T1 to T4. So if you look at the screen, you could say, okay, pretty much I can see how T1 to T4 cutaneous distributions are illustrated, right? It's going down the arm, across the chest. Now, if a male is experiencing this, you would probably say, okay, they might be experiencing a heart attack, right? However, this is not the case with females. If a female has a heart attack, their signs and symptoms are a bit different, and they're not actually per se cutaneous sensations. Now, you might have some chest pain, sure. However, other sensations that women normally feel are shortness of breath, nausea, vomiting, a feeling of impending doom, and fatigue. Now, this picture does not show that. So, with what I'm trying to say is, essentially, this is another example about how this referred pain chart is not with the best accuracy, but for the reason that we're still researching it. We still don't really know. However, it is very helpful, this chart, in how it can provide at least some sort of direction to provide us rationale with whether we should keep a patient or maybe refer them out. Now, with respect to studying this, unfortunately, again, this is one of those topics that, if you're a person who likes to know the backstory and why things are the way that they are, this is, unless you want to go into research, this is just one of those situations where, again, research is just being done because we don't know yet. It continues to be done because the accuracy is not there. Now, let's talk about the application of referred pain. The accuracy of these schematics versus your patient's actual symptoms, make it a little bit more challenging because it's not totally accurate. But it is a really good diagram to know generally to be able to help people get referred to the right clinical specialist. So let's say someone comes to you with low back pain. You're doing all these special tests, and maybe you can kind of elicit their symptoms, which is the goal with your assessment, right? I mean, you're trying to elicit their pain. That way you can say, yes, this is their source of pain. But let's say you're, assessing this person, and you're pressing on your back, and they're like, yeah, it's kind of my pain, not really. And you go through a few sessions with them, stretches, strengthening, abdominal bracing, whatever it may be that you find. And they're also incredibly diligent with their exercises, saying, yes, every single day I'm doing your exercises. Now, what if that situation ends up being to where this person is continuously still having their pain? Nothing that you do or that they do can alter their sensations, right? So maybe this could be a situation where maybe it's actually a visceral pain. Maybe they're actually having, if you look at this illustration, kidney pain. Now, hopefully, there are other questions that you should be asking to rule in and out visceral symptoms, but sometimes, again, everyone's a little bit different, and this could be a way for you to gauge a true diagnosis of a patient, whether it's something that we as physical therapists can help out with, or whether you might need to refer back to the doctor. For those of you who are beginning your NPTE journey or maybe in the middle of it, just wanted to give you some resources. So as you know, I'm the instructor behind SPT with me. We're all about courses and lectures, so you're watching videos. Now, if you're interested in getting more practice questions, check out Typical PT at typicalpt.com. I've checked out their material myself. There's a lot of info. I would definitely say to check it out. As always, I hope this material helped. I hope you understand referred pain a little bit more and understand the application behind it and what actually, in theory, is going on the physiological scale. If you liked what you saw and you're preparing for the NPTE, check us out at sptwithme.com.